for coming. We really appreciate it. Don't mind my notes. Just want to thank you all for joining us this evening. This is our second lecture at Intermountain Primary Children's Hospital, so we're very excited to keep this going. Thank you to Melanie and the rest of the behind-the-scenes team for making this happen. Bobby Jones CSF would also like to extend a special thank you to everyone that donated tonight. If you would like to do so and you haven't, you can visit our website. It's the big gold donate button. The website is bobbyjonescsf.org. No pressure. And of course, huge thanks to Dr. Brockmeyer, Dr. Ravindra, and Mindee Kunkel. Right there. Thank you. The mask got me. We so appreciate that you're donating your personal time for these important meetings. I'll do a mini intro for our speakers, and then we'll just jump right into it. So Mindee Kunkel is the nurse practitioner for the spine program at Primary Children's Hospital. Mindee is the lead provider for the pediatric spine pain clinic at Primary Children's, which includes physical therapy and integrative medicine. Dr. Douglas Brockmeyer is currently professor of neurosurgery and the chief of the Division of Pediatric Neurosurgery at the University of Utah in Salt Lake City. He is the scientific chair of the Chiari Clinical Research Consortium, a multi-center prospective observational study created to identify clinical and radiographic variables that predict success in Chiari surgery. Dr. Brockmeyer is also on the executive committee of the Bobby Jones CSF Scientific Education and Advisory Board. And Dr. Vijay Ravindra is the board-certified pediatric neurosurgeon currently practicing at the University of Utah in Salt Lake City. He is also a member of the Bobby Jones CSF Scientific Education and Advisory Board. So with that, let's get started. This is Dorothy Poppy, the Executive Director of Bobby Jones CSF.
Yeah, I wasn't planning on doing this, but first of all, welcome. And we're going to have some great presentations tonight. Education is key to Bobby Jones CSF, as well as research, which you're going to hear about tonight. And then when we're all done with our lectures, an important reason that you're here in the room is that you are part of the community and part of the family. And it's really important that you don't go on this journey alone. I have a son who had surgery, so I know not your exact road, but I understand the roads that you're walking. And we want to provide support to you, which really wasn't there when my son was diagnosed. So I hope all of you reach out to the foundation if you need anything. You're in great hands here with Dr. Brockmeyer and Dr. Ravindra. So with that, I'm going to turn it over to Dr. Brockmeyer. Yes? You're going first, right? Who's going first? Oh, Mindee, you want to go first? Okay, I don't know the order. So please, big round of applause for coming.
Okay, yay. Okay, up and running. All right. So, as I said, Chiari, the patient experience, that's what I'm going to talk about. So, Chiari malformation, how did you get here? Here's a beautiful picture of a Chiari with a syrinx. So, maybe similar to some of your pictures, maybe a little different. You got here because somehow you were diagnosed. Diagnosis can come because of headaches, scoliosis, neck pain, developmental delays like delay in swallow, speech, or gross motor issues, sleep apnea, central sleep apnea, of course, and incidental findings. We have a lot of incidental findings where kids bonk their head, they get a CT, and oh, look, they've got a Chiari. They're just not symptomatic at that point. And we move forward. Okay. Initial workup. This is one of my favorite pictures of Dr. Brockmeyer. Your initial visit, or initial workup comes with a visit with Dr. Brockmeyer and now coming in Dr. Ravindra, where they get a good physical exam, go through imaging, find out what your symptoms are. And then from there, you figure out what your plan is. Do we need more imaging? Do we need just observation at this point because you've got a Chiari, but you really don't have a bunch of symptoms? Let's see how things go. Or are you going to surgery? The decision making behind Chiari comes from, the biggest thing is from what your symptoms are. Do you have debilitating headaches? Are the kids, the little ones, having issues with swallowing or the sleep apnea? Are things lifestyle limiting? And then kind of looking at long-term outcomes as well. So when you've got a kid someone who has Syringomyelia and scoliosis, long-term outcomes. We know that kids that are that are younger, if you decompress, you can actually help the scoliosis. So they're looking at overall long-term. You guys can still hear me, right? Okay. Again, the special consideration of this is scoliosis with the presence of Chiari and Syringomyelia. This is an atypical curve. It goes to the left, and this is commonly what you'll see with a child with Chiari. And that's where we were saying, if you catch this, kids under the age of 10 with curves under 30, if you catch and decompress, many times the curves will stabilize or they will improve as the kids continue to grow. So if you are one of those lucky people that gets to go to surgery here at Primary Children's, and I know there's adults in the room that have undergone this as well, but here at Primary Children's, this is our pre-op room. Once you're set in pre-op, you've talked to anesthesia and everything, then you get the good stuff. You go under anesthesia and your surgery begins. Once you're done with your surgery, you go to the NTU where you stay there for a few days to make sure that you're feeling okay. There's, looking for complications. And then while you're inpatient, if you get to walk around, there's things to do. There's little kids, there's a playroom for the little kids. There's a teen room for our older population, and then for our adult population, they can always go to the teen room or find something to do in the hospital. There's now the new Seacrest room that has broadcasting, that kind of stuff going on in it. There's music and healing, so Sophie's room is always an option if you need just a little bit of peace. And then for the parents, there's the Ronald McDonald room where you can get a little bit of respite, you can get some food, a shower, a little nap, etc. So post-op, right? So now you've had surgery, you're here for post-op, and the goal is to keep post-op pain under control with IV and oral meds. So as soon as you're done, that's what the goal is, and why you stay here at the hospital. Some kids experience nausea for a couple days after the surgery, but this can usually be managed with medications. The reason that happens is because, one, some people don't tolerate anesthesia, and also you're working with an area of the brain that can be kind of sensitive to nausea. But once you're feeling well, you're able to go home and rest. It's always much nicer at home, and the room service is pretty awesome at PCH if you're here, but you'd rather go home, I'm sure. Once you go home, your only job is to rest and get better. Most kids are back to school within about 2 weeks and back to normal activities within a month. So it's a pretty quick recovery when you're looking at the whole picture. Sometimes, things don't always go as planned. There's always a risk of minor complications, including infection in the incision or suture abscesses that can happen. Chemical meningitis, which is what's it called? It's not because it's infection, it's just that you got blood in the CSF. Cerebral spinal fluid leak or pseudomeningocele. Pseudomeningocele now many times is treated with some Diamox first to try to treat conservatively, but if it doesn't work, then you're back to the OR for a repeat surgery. But the medical team does its best to diagnose complications quickly and treat them appropriately. Once you're done, you come back to see us in clinic. Dr. Ravindra's follow-up may be different, but with Dr. Brockmeyer, you're coming up within 6 weeks of surgery. That way, Dr. Brockmeyer is able to look at you, see how things are going, see if your symptoms have resolved, look at the incision, how are things going. With that, if there's concerns, you may get new imaging. There may be antibiotics if it looks like your incision's having troubles, but most often people do really well with this surgery. From there, further follow-up, they'll have you follow up in a year with a new MRI just to see how things are looking, especially sooner if you have other issues, but just to make sure things look good. And if you're having complications, like I said, we'll want to see you sooner. If you have a syrinx, you would plan to get a new MRI at 3 months after surgery to make sure that it's starting to resolve, because you want to keep an eye on that. That's one of the indications that you're adequately decompressed is if the syringomyelia is improving. Okay. So now you've gone through all of this, right? Does this sound familiar to a lot of you? Everybody? Okay. So then what? Am I done with Chiari? Well, most of the time, yes. Once the surgery is successful and there's evidence fluid is flowing normally, you should not have to worry about your Chiari anymore. But sometimes, I put kids on here, but it's true, kids or adults continue to have headaches. If this is the case, Dr. Brockmeyer tries to figure out if you need another operation or a consultation with headache clinic, because we know that headaches are common. And sometimes you've got a mix of both, and releasing the Chiari will release Chiari headaches, but not other types of headaches, migraines, those kind of things. Sometimes other symptoms do not improve as well, so further follow-up is based on your symptoms and depends on the adult or child who had the surgery. Okay. Sometimes things don't go as planned, and they may need to even try, kids may even try, do a trial of wearing a cervical collar to see if their continued symptoms are related to bone position or instability at the cervical spine, at the AII, the atlantoaxial. I apologize for the brain. And so ultimately, if you do a cervical collar trial and it improves, that could tell us that you do need another surgery with a fusion. This is on the rare side. It doesn't happen to everybody, but it's sometimes what happens. Scarring. Do they need a stent? Does it scar back in? Does it block the flow? These things are all possibilities, but they're not the typical experience. It's important to understand that everyone's experience is different and everyone is treated as an individual. So keep that in mind, that your plan may be similar to what I showed today. Your plan may have been different. I know I can see at least one person in this room whose plan was different. Activity after decompression. After the surgery is healed and the area is healed, typically 4 to 8 weeks, you can return to all regular activities. And I love that Dr. Brockmeyer warns of 3 activities to avoid. Of course, bull riding, bungee jumping, and boy or girl chasing. That's what he tells his kids. So make sure you avoid those. And that's kind of all I've got. It's been really wonderful to work with Dr. Brockmeyer and see how he works with his patients. I don't see any little kids in this room that could probably answer this question, but do any of the kids remember at conversation or at talking about surgery what Dr. Brockmeyer said about worrying? Or do any parents remember? No? Dr. Brockmeyer tells all the kids, don't you worry, I'll do all the worrying for you and mom and dad, you just get better. And that's really what the kids need to do, is just feel better and get better after surgery. So that's a typical patient experience. Any questions? Okay, fantastic. Thanks for all your patience with the computer. Yeah, I'm just flipping it out to there so that we can push it to laptop. There you go.
All right, good evening, everybody. I am really happy to be here, and I'm really happy that all of you are here. And as Dorothy mentioned, you are kind of the star of the show. I'm going to say a few words. I'm going to go through this fairly quickly, and then Dr. Ravindra is going to talk. The main event tonight is for you to share your stories. Like Dorothy talking about being part of the community. We have about twice as many people this time as last time, which is really encouraging, and it's great. And these are the faces that we'd like to see as time goes on. I'd love to see this happen, twice a year as things unfold, as the program grows, as Dr. Ravindra, who's twice as smart and twice as handsome as I am, when he takes over here at least, and I'll be working on the adult side and really seeing if we can really make this happen as a community. Okay, there's a lot of big Chiari communities around the country, which you may or may not have heard about or be involved with, but hopefully we can create one here. So we're going to go over a few things. I don't have any disclosures. Anybody know who this guy is? Aside from Dorothy? So this is Hans Chiari. So this is where it all started. So this guy was an Austrian pathologist who, when people would die in Europe, in Austria in the late 1800s. He would cut them open to look at their insides, and he discovered this Chiari problem, and he was just looking at it with his own two eyes. So he wrote this paper in 1891 describing it. And that's still sort of the one of the gold standards. He described three different types, and the Chiari 1 is what we treat today. A lot's happened in the meantime. So in 1986, there was a paper published about Chiari and just how different Chiari patients are from normal patients. That this tonsillar tissue, hopefully this, oh, there it goes, that this tonsil problem here is very, if you look at a whole bunch of normal kids or normal adults, it just doesn't exist. It's wide open. It's very, very different. So this is the first paper to look at that. But that was over 100 years before, or 100 years after Hans Chiari described it. So, and we see the lines. There's different variations of this. Like everybody in the room has their own experience. There's the Chiari 1. This is the so-called Chiari 1.5, where the brain stem here is pushed down below that line, and there's pressure on the brain stem here. So that can happen too. Here's another thing. You can get fluid in the cord, like Mindee talked about with a syrinx. You can have abnormal bone architecture there where the bone tips forward, and we see kids like that, and that can be a severe situation. And then as Mindee mentioned, there's scoliosis that happens as well. So there's a lot going on in this little area of the neck at the base of the skull that causes all these downstream problems. Okay, so what it causes it, you can be born with it, and there's a list of that where the brain is growing, but it's encased by this bony box in a way, and it can only grow so much. But in the brain kind of comes out like toothpaste out the bottom. You can get it acquired due to various conditions. For the adults in the room, there's a common condition called intracranial hypertension, or you can get hypotension, which I'm learning a lot about as I go to take care of adult patients now, and it's more common than you think, believe it or not. The number of symptoms that are out there are as long as my arm, maybe both arms together. I mean, this is just a small list of the potential symptoms. By far and away, headaches are the number one thing, but maybe some or all of your symptoms are on this list. The one I see a lot is brain fog, and Dorothy leads this big research consortium, and we have researchers talking about that, and it's about blood flow to the cerebellum and the brainstem and all the nerve pathways through that area that drive this. So some people come in. I saw somebody today who was 30 years old, and she's losing her mind. She can't hardly talk or think anymore, and she's got a severe Chiari, and I think she's got this. So it happens. So why do we do surgery? Mindee talked about that before. I look at it two different groups. So there's little kids between 0 and 4 years old. They have a hard time swallowing. They have sleep apnea, speech delay, motor delay. That's what that oropharyngeal apraxia is. They need surgery. They can have a fluid in their cord as well. Over 4, it's a different ball game. Typically, kids can describe their headaches, and you can figure out a little bit better what's going on. You can have deficits. But most patients can be managed conservatively. I think we probably end up going to surgery in maybe a third to a quarter of the patients, believe it or not. We see a huge, Mindee has been with me for a long time. We see a huge number of patients in clinic, and most of those don't need surgery. It's very symptom driven. All the measurements and stuff are kind of secondary, and then everything's driven by radiographs. So here's the picture that everybody sees. This is exactly what it looks like at surgery, believe it or not. There's a picture of it, but that's what it looks like. And so we open it up. Remember, we talked about this. If you had surgery with me, it's a cork in a bottle. Try and take the cork out of the bottle and widen the mouth of the bottle to create normal flow. It's exactly what we do, create a space and get that cork out of there. And then we can treat the Syringomyelia if there's fluid in the cord by doing that procedure. If there's scoliosis, it can help the scoliosis. And if there's some type of compression on the brain stem that's causing symptoms, you can decompress that. Or if there's people who have instability where their bones are moving abnormally at the base of the skull, we can fix that too. So here's the problem. So we know a lot, but it's a very complex disease, and there's just a few examples of really high quality medical evidence that we can really rely on. And so, and these are some of these examples. And then, as Dorothy mentioned, there was no prospective study or prospective group. So in 2021, this group of people, I was one of them, and Dorothy's one of the original members of this Chiari Clinical Research Network with, people from around the country, famous people from around the country putting this together. So we wanted to create a surgical severity score. And what would happen if you went in to the doctor and you had a Chiari and they looked at your symptoms and your x-rays or your MRI, they say, well, your severity score is 10 out of 100, so it's not very likely that a surgery would help you. Or instead, it's 90 out of 100, surgery would help you to a significant degree. So in a simplistic way, that's kind of the way the severity score works. It's categorizing complex information to its essentials, clarifying clinical and radiographic variables, and creating classifications and prognosis. So what we did, we took surgical patients. So this project is ongoing. Many of you in the audience are in the study. They're in the registry. I want to thank you for doing that and participating in it. It's a big deal around the country. I'm going to show you why here in a second. So surgical patients captured these variables. And what we wanted to look at, the primary outcomes, the most important things are, what are outcomes that matter to patients? That's what we really wanted to ask. What are outcomes? Not what your x-rays look like or anything like that. It's like, what matters to patients? So, and those are the questions. How much symptomatic improvement did you or your child have? Or I or my child would undergo the same surgical procedure again. Out of those 5-point scores, we need to see 4s and 5s for both of those to have success. Okay, so that's a pretty strict definition. We have all these sites. These are all world famous people, from around the country, and they're all, very dedicated toward this. When we look at kids, and those of you who brought your children who were involved, they're not sick otherwise. Chiari is their main problem. They have headaches, neck pain, maybe some sensory symptoms are the most common things by far. And occasionally they have a syrinx. For adults, it's a totally different story. They have a lot of other medical issues going on with them. Clinical symptoms are headaches, neck pain, sensory deficit, and then cognitive complaints and swallowing issues and brainstem problems. Grab a Coke on the way out. Okay, so the preliminary, this is what I wanted to share. This is preliminary results from this. Is very exciting. The preliminary results from the pediatric arm are very exciting. This is a big deal because you just don't see this in a lot of other studies. So we have 180 kids, 74 have completed, over 80% have achieved a surgical success, like I just defined, which is pretty incredible. And then that's our primary outcome, which is very impactful, but the same thing, it's hard to read all these words and numbers, but the secondary outcomes about your quality of life, believe me, these statistical results are extraordinary, and you just don't see that in other things, in other disease states as well. So the surgery works in a large number of patients, and it works quite extraordinarily. So this would potentially be a potential success score for kids with headaches, neck pain, and the position of the brainstem might be part of it. So this is just preliminary again. So what's the future hold? We need new centers. We have 2 new centers coming on that Dorothy just told me about. New questions. Once we get a bunch of patients in this study, we can answer lots and lots of questions about Chiari. And then questions that matter to you. And that's what we listen to Bobby Jones, CSF, and what they have to say, because we're always talking back and forth, and it's the patient-driven questions that are most important. We always need new people. We always need money, and horizons and insights are important too. Really exciting. So Dr. Ravindra is here, obviously commander. He just finished his service in the U.S. Navy at Naval Medical Center, but most of all, he's now from University of Utah. So we're happy to have him here. Any thanks for your attention. Any questions? Quick questions for me?
The study was pediatric. Do you have any results for adults?
We don't have. That's a good question. We don't have enough patients yet. We have about 40 adults that we've entered into the registry, and only about a dozen of those we've been able to follow for a year. So we just don't have enough to say anything. We had 87 kids, so we're able to say something, and that'll grow as time goes on. But we're actively recruiting adult patients, and that's definitely part of this study. Yes, we'll have more to say about that. Yeah.
I have a question. How do you typically find adults with it or diagnose them? Like, how does one decide, oh, I think maybe that's what it is, I should, is it always just incidental finding, or what?
That's a really good question too. It is all over the map, and some people come in, like people, I saw 3 people today who needed surgery. One, they thought she had a stroke because she was numb and tingling on one side, so they did a stroke workup and they found a Chiari. And one was just bad headaches, and another one, somebody had difficulty walking. So, and they get worked up by other doctors, neurologists or something like that, and they get referred in. A lot of people just don't know what to do with the problem. It's a very kind of esoteric, diagnosis in a way, but when you get into the community, it is very common. I don't know what the statistics are. It's like Vijay, it's like probably, 1 out of 100 people have Chiari, which is a really high incidence. And then it's with, connective tissue disorders, it's with craniocervical instability, it's with Ehlers-Danlos syndrome, it's with POT syndrome. There's all sorts of things that dovetail.
It's kind of a follow-up question. So, our son, we discovered he had the problem just because he wasn't meeting developmental milestones. And so we looked into it. So as an adult, okay, so I saw that you had mentioned though, like one way is you're born with it, and the other way is that you get it or develop it. How, what sort of things are those triggers that would make you develop it?
That's an excellent question, too. So it's really funny how people can come in and they can have an unbelievably severe MRI and they're totally asymptomatic. And people can go along with their life just fine, and then something happens and they start going downhill, and they have a really hard time pulling out of that on their own. Once the pathology gets going, you have a really hard time. So people can go decades with no symptoms. They are totally fine. If people walk in 50 years old, they're fine. All of a sudden, they're going down the hill. So we don't understand that. That's part. How does that happen? I don't know. Nobody knows. That's part of why we're doing this registry. We're doing it in a really robust fashion, so we can answer questions in an intelligent way.
I have a question. Have any other countries done similar studies?
Not like this. That's a really good question too. Not like this. This is an international study. It didn't show it, but there's a center in Australia. So we said English-speaking countries to start with. So Australia would be perfect, or New Zealand. We're trying to establish collaboration. We're going to be in the fall with Italians and other Europeans to try to get them. But it's difficult because it's just getting patient consents and all the language barriers can be hard to do these studies. Yeah.
Do you know if it's hereditary?
In some instances, there is a genetic cause, we think. It's not strictly hereditary. There's probably multiple genes that are driving this. In essence, everything's hereditary. But we were able to identify a gene here at the University of Utah that correlated with a severe form of Chiari, that really bad, complex one. And we saw it in a bunch of families, and we were able to trace it and get the DNA on those patients and prove it. But that's a very small percentage of patients. But some of it is, most of it isn't, I think.
Can you say POTS as postural hypotension?
Yeah, postural orthostatic tachycardia syndrome.
Yeah, so what's the relevance
Yeah, that's a really good question too. So, yeah, so we don't know. I'll be honest with you. So it's a dysautonomic problem. You probably heard that term too, where the autonomic nervous system runs your heart rate and your breathing and all that kind of stuff. And there's at the base of the skull, at the top of the spinal cord, most of these signals are driven or they go through that area. So it's a complex area, and if you have too much mobility there, Dr. Ravindra is really interested in that. That can drive it. The relationship between POTS and Chiari is probably incidental to some extent. A lot of people have EDS, POTS, and Chiari together. That's very common.
So you're not saying Chiari is the cause or causing POTS, but it could be a factor.
Correct. It's a comorbidity. Yeah. Yeah. Hopefully that answers your question. So, yeah, I don't know if anybody knows that answer.
Yeah, I've never heard anyone mention POTS. Like,
Yes.
So it really stood out.
Yeah. Yeah. Okay. Fantastic. Dr. Ravindra.
Go Navy, by the way.
Hey, there you go. All right. Okay. Great. Well, it's a pleasure to be here. And one thing I just want to say before we really formally get started is that maybe I should get this tattooed on my forehead, but I truly believe that we're better together, right? So when we come across complex problems, thinking about these things in groups and organizations like this especially is super important. So, I know Dr. Brockmeyer and everybody here, and I want to hear what you have to say, because that really is going to frame how we attack these problems in the future. And so please speak up. I think the questions so far have been great, and hopefully we'll get a lot more discussion going. So my name is Vijay Ravindra. I am starting as an associate professor at the University of Utah on July 1st, so I actually don't work here yet. So I don't have a badge or anything like that, so don't lock me out. So just a couple of things. I'm just going to give you like a 10-second thing about me, and I want to talk about a few things about where we are now and really talk about personalized care for Chiari malformation. I think that's probably the next frontier of where things are headed. And then we'll really talk about what lies ahead in terms of research interests, and then we'll go through some final thoughts and take any questions that you hopefully had. So a little bit about me. I'm a Midwestern guy. I grew up in St. Louis, Missouri. Go Cardinals, for any Cardinals fans out there. I did my undergraduate studies at St. Louis University, and then I did medical school in Chicago. And I was lucky enough to come here for my neurosurgery training, where I met Dr. Brockmeyer and kind of surgically attached myself to him for many years. During my time here, I was able to get a degree in public health, which really changed the lens of thinking about problems and research. And we were kind of taught to look at things on a population level, which really changed the way I thought about all problems, and specifically uncommon problems. I went down to Texas to do my pediatric neurosurgery training, and then I ended up in San Diego, where I was at the Naval Medical Center in San Diego, where I had the privilege of taking care of our service members and their families. And I also worked at Rady Children's Hospital too. And then I was lucky enough to come back here and start at Primary Children's, which I am over the moon about. And so, the reason everybody's here today is to talk about Chiari malformation and disorders of the craniocervical junction, or where the head meets the neck, right? And so I think about these things from a biomechanical standpoint. So structurally, there's something going on in this area. But we also want to think about it in terms of fluid mechanics, right? There's a plumbing issue. And that's what we're trying to fix. But we're not fixing these things in isolation, right? They're very much involved with one another. So where are we now? Well, I got to tell you, I think we're in a great spot right now. I couldn't be more excited to jump into this thing with 2 feet, because I think we're doing a pretty good job. Things that we talk about in Chiari malformation are, like Mindee talked about at the beginning, whether we observe or we treat. Recently, there was a big randomized trial. Hopefully, that will be released soon. But whether we do a bone-only decompression, where we just take away part of the bony problem area in the back part of the skull and the top part of the spine, or do we do a duroplasty? Some of you might be involved in that study or have been enrolled in that study. And that's a randomized trial, which I'll tell you, neurosurgery is a big deal. And for us specifically who are really interested in Chiari malformation, this is going to be a game changer. Whether we just reduce those tonsils by shrinking them or do we actually have to remove them. In patients that have failed initial decompression, to do a fusion surgery or to go back in and try to re-explore the area. Talking about doing surgery from the front, where we go in through the nose or the mouth and take away compression from that area. And of course, fourth ventricular stenting, actually putting a tube from the fourth ventricle to drain that fluid to give it a pipeline to get to the bottom, a little bit lower than the area of interest. This is all stuff that has really come around in the last 5 or 10 years, and we're talking about it really openly. I show this slide because, I have to think about things very simply. And so there's a structural Chiari where we think it might be driven by the skeletal system or the bones. And then there's this flow-related Chiari where it's really driven by the CSF. And in actuality, it's probably both, right? It's a healthy combination of these two, maybe more so on one side for some patients than the other. And so we need to think about these things in a unique way. I think for me, this is the triangle of life, right? When we're practicing medicine, specifically surgery, I think this is what makes sense. So we're in clinical practice, and especially in surgery, if we have to do a reoperation, it's not necessarily because there's been a failure or there's been a problem. It really highlights a lack of understanding, right? Maybe we did not do the right operation the first time around, and that's because we didn't understand what the natural history of the problem was. So we need to understand who's at risk and who may require additional procedures, and we take this and we do research, and we need to analyze this data to try to tailor treatment and improve outcomes. One thing I'm really interested in is, the randomized controlled trials in these big studies, we really want to think about patients as similar, right? We need to compare similar things because then we can make conclusions. But the truth of the matter is, and Dr. Brockmeyer talked about this, there's lots of different flavors of Chiari I malformation, right? And you can always, this is a little lame, but you can think about it like snowflakes. There are a lot of differences. So what if we talked about taking a patient's symptoms like scoliosis or headaches or syringomyelia, and then we take their imaging studies, which everybody gets, right? Everybody gets an MRI. Everybody probably gets x-rays at some point, especially if you have pain. And think about what kind of tailored surgery we can offer. And SOD, suboccipital decompression, that just means we take away some of the bone from the bottom of the skull and the top of the spine. You add a second D there, and then we're talking about doing a duroplasty. And then the third part is fusing the spine to the skull to try to prevent any increased movement in that area to really promote, cessation of the symptoms that one may be experiencing. And so the goal of tailoring surgery and getting the right operation for you is to improve outcomes, have the potential for less reoperations, but get rid of those symptoms without introducing more complications, okay? So one thing that we've really talked about is doing this with CSF flow. So Syringomyelia, the CSF at the base of the skull and top of the spine, there's a problem. It's a plumbing issue, right? We know this. And, in Syringomyelia and Chiari malformation, we know that actually the way our heart beats, it's keeping us alive, but it's making that problem, that Syringomyelia, worse, okay? And so we were able to hook up with a group of engineers in San Diego, and they actually, in a very complicated way, figured out a mathematical equation to understand how the syrinx grows. And I thought that was just the coolest thing. This is some of the work that they've put out. I'm not going to bore you or try to act like I understand what's going on here because I'm not a mathematician. But this is really impressive stuff. But as simple-minded as I am, I say, well, let's talk about how we can help patients with this, right? It's great to do it, in a setting with computers and mathematical equations, but how does this help patients? So now we're talking about taking a patient on the left. This is a patient of mine who presented with left arm numbness and weakness while playing volleyball, and she was scared out of her mind. And she had a really impressive MRI scan. And she underwent suboccipital decompression and duroplasty, and that's a 3-month MRI scan. You can see it's completely different, completely gone, right? But I don't know what the CSF flow at the area of interest looks like. I could probably guess, but that's about as good as it would get. So what we really want to do is take MRI imaging and try to compare it to this mathematical modeling and really figure out what's going on. And this is how we're doing it. This is just kind of a simple cartoon that shows just a standard MRI that everybody in this room has probably undergone. And then we take that MRI and we build this 3-dimensional model. And then what we do is we use the MRI to calculate the velocities of the spinal fluid, and then we're going to compare the two. Okay? So what this will allow us to do is really understand the flow of cerebrospinal fluid in this area, and we're going to try to use this to think about how to tailor surgery. Okay, so patient X has this amount of flow in front of the spinal cord. What do they need to get better? What do they need to have an improvement in that flow? And hopefully we can get to the point where we can resolve symptoms and not introduce complications. Okay, this is something that we're enrolling currently here at Primary Children's, and it's a really cool study, and I think this is just a reflection of where the field is headed. And the most important thing, like Dr. Brockmeyer talked about, is we can look at MRI scans and say, yeah, that looks great, but what I really care about is how you feel. Are you better? Are the symptoms you presented with resolving, or are they at least stabilizing to where you're not worsening over time? And this is where the rubber meets the road, right? Patient-reported outcomes matching what we're looking at. And that's the future. And the ultimate goal is to decipher who benefits from what surgery. We talk about this a lot. I think so-and-so might just need a bone decompression. And we're using some information to make that decision, but boy, it'd be great to have some really detailed information and some objective data, some numbers to say, yeah, this makes a lot of sense. Okay, and I think this is kind of the next frontier of tailoring treatment. And what we might find is that we're spot on, and that would be great. We might find that we have some room to improve, and we would love to hear that also. So this is kind of an exploration to help refine what we're doing. I labeled this future directions, and then it really is kind of future directions. Don't worry, I have a future directions too. But we really need to think about the tissue in that area. So there's this thing in neurosurgery that when you're a hammer, everything looks like a nail, right? But there's other areas of interest here, the muscles, the other soft tissues in the area, the fascia, things like that all of us have that may be related to this. And I think ultimately what we'll need to get to is comprehensively looking at all these things together and leveraging technologies like artificial intelligence and high-frequency computational modeling to come up with this Chiari-omics, where we can look at a patient, plug your MRI scan into a computer system and say, this is what this patient has. This is what they need done. Now, this is 15 to 20 years, hopefully, down the line, but I think this would really simplify the way we think about complex patients. And then we have future directions, right? So there's lots of work to be done, and I'm really excited about this because this is what gets us up in the morning, right? We love taking care of patients, but we want to make our patients really do well and get better and get back to what they love to do. And that means that we need to figure this out. And so ultimately, I think minimally invasive, non-surgical interventions are where we're headed. Not only to augment CSF flow, but maybe we're augmenting tissue properties. Maybe we're talking about things to relax the dura to promote more flow, or relaxing the ligaments. And the reason I'm speaking in generalities is because this is a pipe dream, but it's a pipe dream we need to work towards. And this is my hope. We also need to know what the priorities of the people that matter are, which are the patients. So in my mind, I know what I want to accomplish when we look at stuff like this, but your goals may be different, and that's great because I want to know that. I think our patients are not just our patients, but you're part of the journey, you're part of the collaboration. And a lot of these organizations that sponsor projects require patient groups to be part of it. And I think that's the best idea I've heard in years, because then it really is going to have an impact on the community. So patients need to have access to cutting edge clinical care, and that should really be the standard. That's not something special, that's just the standard. But these exciting research opportunities need to be part of the equation also. I am really excited to be here. And I want to thank Dr. Brockmeyer, who's been a mentor and really paved the way for everything we're doing, everything that's been done, and the sky is the limit, and he taught us that. And so we need to think outside the box and move forward. And I want to thank Bobby Jones for the invitation. And actually, this was scheduled so I could be here after my move, so I really appreciate that. And yeah, we're pumped. That's my cheese ball there who made the journey with me. So we'll take any questions, and thanks for your time and spending your evening with us. We really appreciate it.